Afternoon, everybody, and welcome to this discussion, this very crucial discussion on the rising issue of heat in our cities. And as you know that in a warming world, our cities are simmering in heat. Urban heat island effect, which on the one hand is fostered by concretization, loss of natural heat sinks, which are green cover, water bodies, and on the other hand, anthropogenic heat sources such as vehicular exhaust, air conditioners, industrial emissions, landfills, burning of waste, air pollution, which blankets our air, all this together traps heat, and all these together convert our cities into boilers. Now, with this aggravating issue, we have with us our guest for today, Dr. Ajay Chauhan from RML Hospital, Ram Manohar Lohia Hospital, New Delhi. And we will borrow his expertise to highlight some of the very important issues related to the impact of heat in our cities and how we can reduce it, especially for the vulnerable groups. So beginning with that, Dr. Chauhan, I'll ask you, first of all, how has heat impacted our city over all these years? And which are the ones who were, affected very badly?
See, heat has been a big issue, especially in this northern belt and in and around coastal areas of our country, peninsular India. But being limited to Delhi, my experience, I'll recount all the clinical experience which I bring. So we always had heat in earlier years also, but in 2024 we saw an unprecedented rise in the number of cases of heat stroke which we got, and maybe it was the tipping point of it was a culmination of years of misplanning and mismanaging our city, and on the top of it, it was exacerbated by climatic factors also. And ironically, the most unfortunate part is the brunt falls on the people who are most vulnerable and down the ladder, so very low in the socioeconomic strata and unaware. So what I saw over last year was that the patient which we got in our hospital of heat strokes, which is most severe in the spectrum of heat-related diseases, the most severe of them all, carrying a very high mortality rate, were from urban slums, factory workers, hawkers, drivers, street vendors. So they felt the brunt.
Correct. You very rightly pointed out that outdoor workers are one of the most vulnerable groups in our cities. We now have evidence for this because CSC has conducted a 9-city analysis over 10 years, and especially in the cities that have very high population. We found out that more than 5 cities of these 9 cities have 80% of their areas, geographical area, under heat stress. And also, when I say heat stress, I mean areas that are consistently experiencing temperatures, land surface temperatures above 45 degrees Celsius in summer months. And in these months, heat is affecting all the regions alike, be it plains, hills, be it coastal areas or any other area. All these areas are getting affected by heat. In all these areas, because these are highly urbanized cities that we've analyzed, we find out that the vulnerable population, the outdoor workers and people who live in slums, face the biggest brunt of it.
Yes.
And which is why we are also conducting vulnerability assessments. For example, cities like Kolkata, we have found that this chunk is quite huge, and not only for Kolkata but all these big cities, because they're an attractor of jobs. And a lot of people migrate to cities in search of jobs. We have a very big informal sector in these cities, which means that the vulnerable group is quite big in all these cities. So, and also these workers not only work in an environment where there is limited cooling. These people, they live in an environment where their houses are also not equipped with the cooling mechanisms. So, how do you think we should, incorporate consideration to these groups in heat action plans? Because you know that we're making a lot of heat action plans these days.
See what when a patient comes to us, it is already too late, because heat stroke carry a very high mortality rate. Between 40 to 80% of people die if they really suffer from what is called as a heat stroke. And here, preventive aspects of heat-related action plans have a very, very big role to play. People can really, it's not only a cliche that penny spent is in prevention is worth a pound of food. So we see it daily on ground while dealing with such patients. So we should launch a blitzkrieg of public awareness measures in addition to all the other factors which can be done in terms of building infrastructure, making heat sinks, planting a lot of trees.
Right.
That being said, but there are some concrete measures over and beyond this, which, in my opinion, can be instituted. These are, and we will need a very tight regulatory framework for this. So, we had this year in our hospital, which is a central government teaching hospital. So we had about 75 cases in 2024, out of which unfortunately 27 died. And overwhelming number of these were people who did not have any knowledge about what to do. And the physiology of human body here, I'll put in the clinical perspective, is such that a person, somehow it is yet unknown if a person is doing a lot of manual labor in a high heat surrounding, he become acclimatized. There is a great acclimatization potential in human body. So the sweating rates increase as many as 8 folds. Cooling ability, the skin flow increase by as much as 20-fold. By meaning thereby, they have a great propensity to tolerate. But the classic heat stroke will happen in such a situation that this patient, acclimatization takes weeks and months. But physiologically speaking, de-acclimatization is very fast. The classical history will be this is kind of rickshaw puller, laborer, military personnel doing a pit crew on his back and running 30 kilometers, industrial worker. They will be working and then they will go to their hometown, then they will come back and they resume activity at the same level and they suffer from heat stroke.
Right.
Moreover, there is a very, very, very important role in preventing heat stroke. So we should, and it's a composite of both humidity as well as temperature, besides air temperature and radiant heat. So we should give every facility, it should be mandated that every facility, maybe it's a close surrounding in which a lot of people are working, should mandatorily have a wet bulb thermometer. If not that, then they can, just measure the temperature with normal thermometer. And if there is a high temperature, high humidity, they should ask their workers to take a break of 15, after 45 minutes to 15 minutes, there is a chart at how much temperature and how much time does a worker need. Unfortunately, I have attended too many of such meetings in which heat stroke, there are two popular misconceptions, very big myths. Here I would like to bust them through you. First, heat stroke is not equal to, although it's a very important thing in managing, but not equal to giving ORS packets, distributing ORS packets, giving arm panna. This is not, hydration is a very, very, very important component of the treatment of heat stroke, but it is not the most important component.
Right.
Most important component is the prevention. And secondly, bringing the temperature down very, very quickly. That is that most of the even clinicians, they try to treat heat stroke by giving a lot of fluids, which is the wrong. In terms of preventive measures, beside infrastructure changes, what we can do is tough regulatory measures. In some countries in Gulf, they have 3 flags: red, green, and yellow. Based on the wet bulb globe temperature, there is red flag when there is no work supposed to be done by anyone. They have AC tents nearby. So, and when there is a certain temperature rises beyond, and this is not the temperature itself, it's a heat index, which is a composite of temperature as well as the humidity.
Correct.
So when the heat index rises beyond a certain level, they ask the workers to take break at 45 minutes. It even rises less than maybe at 1 hour or 1.5 hours.
Right.
So there it has to be, and so again bringing the medical aspect of it, somehow people who work in heat for a long duration, their thirst response gets blunted. Yeah. So we should make an active effort to a person working in heat, doing high level of manual activity, should make an active effort to replenish his liquid, second most importantly, his electrolytes, his or her electrolytes, both, whether or not he feels thirsty or not. So that is a very important component which people miss out.
Right.
One another factor may be helped by a bystander. If you are suspecting somebody of losing his or her consciousness all of a sudden, rather than ferrying him in a hospital to All India Institute or very big, the time is of ultimate essence in preventing mortality of it. So you should pour water below neck, make him bad, fan him. Something is better than nothing. And you have, if you have something, then do more. That is the mantra of managing.
Right. You very rightly pointed out to the part that exposure plays in impact of heat on humans. So in past we used to, it was our social or moral duty to plant trees, set up piaus, or let's say build shaded resting areas for travelers. We used to do this culturally and socially, but over the years, we somewhat have forgotten the importance of such infrastructure in our cities. We may be progressing economically, but we are losing out on these values. But good news is that we are coming back to these values, and we are exploring such cooling solutions for cities. CSC is researching into this. Here I want to highlight that we are simulating, how these cooling solutions, such as shaded walkways, shading devices on streets, and water elements like fountains, then vertical gardens, and such other trees and plantations that have a thick canopy. We know that these solutions can bring down the ambient temperature by 7 to 17 degrees. The range is such high. It was also surprising for us. But we see that these solutions work. And the effort now is on to promoting these solutions and also integrating these solutions with the master plans. And the government is recognizing these solutions because the government has asked to prepare climate action plans and integrate them with master plans and building bylaws. So, what do you think could be, the role played by these cooling solutions at a city level? Do you think this will have a good impact, especially when we talk about the vulnerable groups?
Okay, you spoke about development. So I think the urgent need of our country is to redefine the paradigm in which we fixated on development. To see what is development.
Right.
To really, and it has wider ramification because this not only relates with heat but with other factors also, including air pollution. So we have to redefine the what is development. Time is right, then whole world sit back and look at a wider basic level, fundamental level. And if at all we are developing city, we should develop more walkways and more, more cycling tracks, less of this rampant, unplanned, cancerous urbanization,
Right.
which is happening in every, forget about metro cities, and there's an insatiable greed to make more and more buildings here and there. And it pains my heart actually to see you venture out in 20, 30 years back, what used to be green area in our cities
It's
entirely lost.
Right.
So there's urgent need. I think we have reached a tipping point. So everything and everything, I'm a vociferous supporter of all the things because when we see a person, it is very, very late. So all things done for prevention will indeed save a lot of mortality. Last year we had about 45,000 cases of stroke, and from 2015 to 19. The recorded numbers are 755 a year if we average the number over these 5 years. So there's a, and I'm no climate expert. I'm a clinician, but still from my gut feel, I can say that this weather problem is climate change is going to be, very difficult problem to, contain. Every year we hear that this year is the warmest year. Same happened in 23, then 24, and I wish I am wrong, but I think 25 will be even warmer.
Yeah, the projections are that we are going to face warmer months every time. You've raised a very important point of the data that is there on such diseases. So we know that there is paucity of epidemiological studies and related data. Can you throw some light on what measures are now being taken to bring this data together?
See, that is their average number of deaths, average number of heat stroke reported in India was from 2015 to 19 is 755 per year. If we see US, which is about one-fourth or one-fifth the size of India in terms of population, it is a much more cooler country because it is in temperate zone. We are much more nearer to the equator. So if you see their number, it is about 702 per year as given by the CDC. Europe, if you include that massive heat wave that happened 5-7 years back, then the data is about 7,000. Europe is nearly 80-90% of India in terms of population. So if you compare our data, despite being a very, near to the tropical country, still our data is very, very, very less vis-a-vis other developed countries. The only plausible reason might be that we were capturing less. So NCDC and National Program for Climate Change and Human Health launched a very massive effort in order to sensitize everybody, especially doctors, to identify that heat-related illness. It's this entire spectrum. Heat stroke is the very end point, high fatality, but before that is heat exhaustion, heat edema, heat syncope, and then we have heat tetanus. There is multiple things which happen before heat stroke does. So now with all this mechanism, last year and 2024, all of a sudden from 755 here we had 45,000 cases being reported. So the reporting has, thankfully, we are sensitized. Now the next step is curing it in a timely manner, which again require high degree sensitization, but over and beyond, again and again, at the cost of repeating myself and sounding like a broken record, prevention has the main role. All preventive measures we should go all out, because otherwise this is going to be very horribly hard problem to manage if it continues to grow with such an exponential rate as we saw last year.
Yes. On this note, Dr. Chauhan, please tell us a little bit more about the heat stroke unit that you have set up at RMU Hospital.
Yeah. I am happy to announce that our hospital set up first of its kind heat stroke unit. I don't think there is anywhere it has been done in India, right? So what we have done is we have envisaged that heat stroke unit will have two components. One is the mobile component and one is the static component. Mobile component being important because a lot of times we get these messages from ministry that there is an election rally or RML is called because there is a marathon or half marathon take place. So we will have a mobile unit. And in heat stroke management, one of the 5-6 golden rule is time is of essence. So the early institution of cooling measures is of very vital importance in saving lives. So we have in our ambulance, we have inflatable tubs, 2 of them. We have ice-lined boxes which can contain 25 kilos of ice. This is the mobile element. What is static element is in a room of about 24 feet by 12 feet, we have about 4 ACs full. And then we have 2 multi-para monitors, 2 ventilators. And then besides that, the most important thing is we have ice-making refrigerators, which can make 250 kilograms of ice. And we have 2 large-size tubs. Any hospital can set it up very easily, like bathing tubs. And they can be rapidly filled with water. To mix 150 liters or 50 kilograms of ice in 150 liters of water, the temperature comes to around about 0 to 5 degrees centigrade. And the recommended rate of cooling in a case of heat stroke is 0.15 degrees centigrade per minute. And the only way you can achieve that is by immersion cooling, which we have in RM hospital. Fanning, putting ice in axilla here and neck, axilla is a medical term, where your arm meets your body is called axilla. So, and groin. So these are unable to provide the cooling rate which is desired in a case of exertional heat stroke. They are unable. In fact, they are 1/10 as efficacious as dipping a person in water, cold water. And we have been able to save a lot of lives. And although it was very difficult, overwhelming number of our patients belong to 30 to 55 years because they were labeled, just as I told you, labeled as hawkers, street vendors, door-to-door salesmen, security guards. So we had an overwhelming proportion of exertional heat stroke as opposed to classic heat stroke. There are 2 kinds. So this is our setup.
Okay.
That is
all right. So this mobile heat stroke unit sounds quite interesting. Why I'm saying this is because in our research we have found that there are areas, especially areas like flooded factories or informal settlements. Now these areas use roof materials such as tin sheets, galvanized iron sheets. So they are quite these are definitely heat trappers. So
Yeah, I would like to interject. I apologize for interjecting there, but there is a small story I would like to tell. Although doesn't reflect statistics. With this disclaimer, I'd like to tell you one of our patients who thankfully survived was a worker in a pipe factory. This PVC pipe it makes, Delhi. Yeah, he came 38, 39 years old from resident of Bihar. He was migratory labor and he came in a very horrible state. And what was the reason behind that? It was covered by a tin roof as a corollary to what you are saying. And the building had no coolers. Forget about the cooler and fridge. The building did not even have a drinking water. And I asked, did you drink water at regular interval? Bola ke saath niche, if we drink too much of water, we'll have to go to loo too many times. So that is the very pathetic work condition.
That is very unfortunate. And I was raising this point because these areas, in a city, in plans, we see these areas geographically. We can spot these areas, identify these areas where the roof material is not as good. So this is just one indicator of the settlements which may not be able to cope with the heat because due to lack of natural ventilation, due to too much exposure to the sun, because of poor shading and too much exposure. So how about how is this idea of making the mobile unit available to such identified places?
See here, mobile unit is curative in its approach. We are curative in approach. All this, what you allude to, is preventive in approach. There is no role of a mobile unit in prevention.
Correct.
Which again, third, fourth time repeating is more important than cure.
Prevention.
Mobile unit is for suppose there is a election rally. People are last year we heard the unfortunate news of 3-4 CISF Chauhans. I mean, succumbing to this heat stroke. They were out on duty in this election to cover election. So that for that kind, there is a rally taking place, or there is a voting booth which doesn't have adequate shade. So then, or there may be a marathon which has to be covered in a mobile unit. That is what a mobile unit is for, an ambulance equipped with cooling, fast cooling mechanism.
Right.
It is not for preventive.
Right. For prevention, definitely we have to look at a more permanent
solutions. We have ancient wisdom covering that roof stain with gobar, that cow dung there, and there are some heat resistant paints also very cheap to use.
Yes, reflective paints.
A lot of people have done a lot of work on this.
Absolutely. Part of our research is this only. So cool roofs, green roofs,
yes.
And increasing the reflective index of rooftops using material that does not allow the heat to penetrate inside the roof, through the roof or through the walls. Shading devices and trees with the thick foliage to cover the shaded walkways. Fortunately, the codes that we have now are incorporating features like these, and what we need now is a very planned, in a very systematic way, in a very planned way to scale these up at a city level, so that as you're saying, prevention is very, very important. So, as we move towards closing this discussion, Dr. Chauhan, can you highlight a few symptoms by which a common person can, know what are if he or she is going through a heat-related illness?
See, this is, we should not rely on symptoms too much. We have to rely on science in this case and science is not SCI wala. It is SIGNS, science of it. So symptom, it is a pretty, symptom vary from person to person. It's a myriad of symptoms ranging from nausea, vomiting, diarrhea. That also can be a symptom of heat exhaustion.
Okay.
Flu-like symptoms. And at the very culmination, however, the symptom is the heat stroke is said to exist when three conditions meet. One, core body temperature. That is, what is core body temperature? Temperature taken with a thermometer inside rectum of a human being is called as core body temperature. Okay. And there is no alternative to it. It is, the body temperature cannot be accurately measured by putting it in axilla or anywhere else. If a core body temperature is more than 40.5 degrees centigrade or 105 degree Fahrenheit as we use in our country, one. Two, alteration in consciousness. If a person is suddenly speaking, he is losing his consciousness. Second. And third is history of heat stress. Now, two are very easy to identify. 45 points, it's an objective thing. You put a rectal thermometer, check it. Second is also very easy. If a person has lost his sensorium, altered sensorium is very easy. You can make out that I and you are compost mentis. Suppose somebody is stuck. The third is the tricky part. Third doesn't entail, it is a heat stress. And heat stress doesn't mean it can exist right here. If we are playing a game of squash and the AC is switched off, it is a condition of heat stress. So their clinician's judgment has to come.
Right.
What is a heat stress? If these three conditions are met, most of the differential diagnoses are out and we label a person as suffering from heat stroke. It is essentially a clinical diagnosis, need not do this investigation and that investigation. In certain cases, we have some doubts, like an army jawan doing sentinel duty on the border in a bar there. Now you think whether it is snake bite or it is a heat stroke. In that scenario, we require to do some investigation.
Right.
Or a old person, Rishwapula, suddenly collapsing, whether it's stroke or a heat stroke. Then we need to do a CT. All the investigation are done to rule things out. But insofar as heat stroke per se is concerned, it is a diagnosis essentially clinical.
Right.
So it is clinician's acumen, his sensitization, his level of alertness, which will enhance, early diagnosis. And early diagnosis saves lives.
Correct. Very well said, Dr. Chauhan. And I think this is the most important message that we want to relay on this World Health Day. And I thank you again for sharing all this information on, how prepared our cities are in terms of healthcare when it comes to managing heat-related illnesses. And cannot say enough that prevention is something that we really need, and prevention can only happen when we enable our cities to cool themselves down, which they're not able to do these days because of the way we are planning and because of the way in which a lot of concretization is happening, anthropogenic activities, which are huge contributors to the problem of heat, and also how the heat sinks are depleting and just reducing in our cities. So we need to have all this worked out in a very planned way, and we need to integrate all this action in our master plans. And CSC is working on developing guidelines to enable this. We are conducting vulnerability assessments in cities to find out which of the cities and what is the kind of vulnerability that they're facing the most in these days. So for that, I want you to keep in touch with CSC, stay tuned with CSC to learn more about these initiatives. And thank you once again, Dr. Chauhan, for being with us, and have a very happy World Health Day to everyone. Thank you.